historically, there has been some tension between agency owners, agency chiefs, physicians, and medical directors. That has gotten significantly better over the years. And part of this is going to spend a couple minutes talking with you from my perspective about why the engagement with a medical director is critical to a successful agency. All of the examples that have been provided heretofore today about agencies that have made very progressive changes in their response activities, in their clinical care activities, are because they have had a very well-informed, dedicated medical director to work with. So these are disclosures. It's small print because you don't need to look at that, and I'm going to move on. I don't have any conflicts other than a bias that medical directors' active involvement is critical to successful EMS engagements now and will be more critical in the future. We're going to spend a little bit of time talking about the federal and state roles in medical direction, medical oversight. I'm going to make a distinction between an EMS medical director and an EMS physician. And that distinction will become apparent in just a couple of minutes. We're going to talk about the roles and responsibilities of a medical director and then level of engagement. I have to say this because I spent 15 years in the federal government, 5 plus with the National Highway Traffic Safety Administration's Office of EMS. There is no federal requirement for medical direction of EMS activities because there is no federal requirement for EMS in terms of operations or anything like that. The Office of EMS at NHTSA functions as the de facto lead agency for EMS at the federal level and has done so since the late 1960s when the white paper was first produced. There are a number of other federal agencies that are actively involved in EMS activities, all of which acknowledge and encourage the importance of active physician involvement in EMS. Just to give you an example, and we talked about NHTSA, there are guidelines for medical oversight, medical direction. Obviously, National Association of EMS Physicians and ASAP have resources and are very deliberate in encouraging physicians to be involved. FEMA put this handbook for EMS medical directors out now over a decade ago that is in the process of being updated. In terms, and one of the reasons that there is no federal requirement is it has to do with the states' rates issue, okay? States are responsible for regulating and oversight of EMS. So actually, half of the state table is gone now. But the folks at, let me back up for 1 second because I wanted to make a comment about the federal activities. You know, everybody jokes about the fact that, hi, I'm here from the federal government and I'm here to help you. I can tell you unreservedly that all of the folks at the federal level that are involved in EMS activities, whether it be at the NHTSA Office of EMS, Department of Homeland Security, FEMA, HHS ASPR, those folks that are involved in EMS activities know EMS. They know okay? They have come from the field. A majority of them are still in the field. And they approach their activities from the perspective of how do we make the system better? So, you know, we've, particularly this time of year after the election and before another administration transition, we have concerns about federal bureaucracy. There is federal bureaucracy, but the folks at the federal level that are involved in EMS understand it, and they're on your side. But as this alludes to, EMS is regulated at a state level, and it's regulated in all 50 states and territories at the state level. Ooh, Emily's frowning at me. Okay. Michigan does have a state EMS medical director who is a consultant to the department. Fortunately, none of the MCA medical directors or local medical directors are responsible to Bill Fales, nor does Dr. Fales have any authority over those medical directors. No, actually, Matt didn't, but you missed Matt's, anyway. And I don't say that to be derogatory, but at most state levels, the state EMS medical director is a consultant and a resource, both to the state EMS office staff and to all of the agencies within the staff, okay? In Michigan, we have, as part of our regional system, regional EMS medical directors working on a number of activities. Again, they're there to work with the folks in the system, and then a local EMS medical director. The state does have requirements for an EMS medical director. It's stated here in the law. Essentially, it's summarized in this page from the Medical Control Authority handbook that the state puts out. In Michigan, medical director has to be board certified in emergency medicine or practicing actively in emergency medicine and having ACLS and ATLS. That's the minimum. That doesn't apply in all states. In some states, if you're an MD or a DO with a state license, you're qualified to be an EMS medical director. And then the legislation also outlines the roles and responsibilities of the medical director as it applies in Michigan. This is where I'm going to start to make a distinction between a medical director and an EMS physician, because the title related to EMS physician. When I started in EMS, and it was longer than the longest reference that was made, my medical director was an orthopedic surgeon. What's that? They wrote the book, yeah. The first AAOS textbook, the Orange Book, was from the American Academy of Orthopedic Surgeons. Orthopedic surgeon, signed the agency licenses, gave one lecture a year to the training program. I knew who the medical director was, but otherwise didn't see him. We still have medical directors who are signature-only medical directors. And if you're this is going to be really heretical on my part, and you can blame me for saying this. If your agency works with a medical director that is signature only, talk to me and talk to the state, because that's got to change, okay? A lot of medical directors out there now are emergency physicians, hopefully with an EMS interest. EMS residency programs cover issues relating to EMS and clinical care and response times and appropriate equipment and non-appropriate equipment and things like that. So there are a lot of very good medical directors who are emergency physicians with a special interest in EMS. We're starting more and more to talk about EMS physicians, and EMS physicians are board certified in emergency medical services. We'll talk about that more specifically in just a second. They are physicians who have dedicated their professional clinical career to EMS. And as we've talked about time and time again so far today, with a very strong emphasis on evidence-based clinical practice. Now, the big problem that we've had in EMS forever and ever and ever is that we have not had a lot of evidence upon which to base our clinical decisions. But that's been evolving over time. And in the last 5 to 10 years, it has evolved significantly into many areas that we have talked about earlier today. So EMS subspecialization, true EMS physicians. The American Board of Emergency Medicine recognized EMS as a subspecialty area in 2010, offered their first exam in 2013. There are currently a little over 1,100 board-certified EMS physicians in the country. We're very fortunate in Michigan because we have a fairly good number of EMS boarded physicians in the state. There are currently 75 fellowship programs, 4 fellowship programs in Michigan. And for the folks who are not involved in fellowship programs, where are those located? Number one. Give me the 4 locations of a fellowship program here. Say, well, no, okay. The state folks piped up. Saginaw? Okay, we have one brave person up in front here that says Kalamazoo at WMed is the only one that matters. Anybody else want to take issue with that? Okay, we've got Michigan folks back here. We've got Wayne folks back there. Okay, so the 4 programs in Michigan are Kalamazoo at Western Michigan, Homer Stryker School of Medicine, University of Michigan at Ann Arbor, Wayne State, and Central Michigan / Saginaw Medical Control Authority. When we talk about the medical director, I sort of alluded to this a few minutes ago, but it's got to be viewed from the perspective of a partnership, okay? This is obviously an old slide. This photograph was in GEMS in late 1978-ish, somewhat. Okay, so you've got medical director, a field clinician, and the fire chief demonstrating the agency chief. I would suggest to you that all EMS policies, procedures, and protocols are clinically care related and are therefore the practice of medicine, okay? Dr. Kupis has coined a phrase that many folks now use. The policies, procedures, and protocols list the clinical indications for the care that is being provided. So what we have done historically, and the model still applies, but I want to change perspective a little bit. This square is the EMS agency, and whether it's a fire department, a volunteer agency, a for-profit, whether it's the Medical Control Authority, and all of the other agencies within the Medical Control Authority, look at the gold highlighting as operational or administrative activities. Look at the blue area as the clinical activities, okay? As you get more and more toward clinical engagement, the medical director comes into play more and more. As you're into administrative and operational activities, the agency chief is more and more involved and responsible. But at all levels, there has to be engagement between the medical director and the agency leadership. There is no clinical activity that we do in EMS that doesn't have operational implications, okay? I mean, this goes back a number of years, but in Kent County, when we first talked about implementing 12-lead EKGs, so that was a number of years ago, okay? From a clinical perspective, it made all sorts of sense to roll out 12-lead ECGs, the LifePak 12. because we could better take care of patients. But to do that without thinking about the operational implications of how much do the LifePak 12s cost, how much are we going to have to spend on training them, how much are the maintenance activities and things like that. Likewise, as it relates to agencies providing clinical care to patients, there are no operational decisions that don't have implications to clinical care. So we may have, a separation between operational and clinical. I don't think we do. There has to be close engagement at all levels. Now I'm going to sidestep and do one other thing in closing, having to do with the implications of EMS. And we experienced this a number of years ago in Kent County. I noticed it a lot at the federal level, in engaging with the federal emergency management community and some with the state emergency management community. It was confirmed without question during the pandemic. In the Agenda for the Future in 1996, we talked about EMS being the intersection between healthcare, public health, and public safety. There's a lot of discussion now about whether that really still applies, and it's my opinion that it does. The problem that we had with the Agenda for the Future is we designed all of those circles in the Venn diagram to be the same size, and they're not. EMS is primarily healthcare, and I think we pretty much accept that. EMS is becoming more and more involved in public health activities, and that will continue to increase, no question. EMS is affiliated with public safety, not for the obvious reason that a good share of EMS response is provided by a public safety agency, i.e. the fire service. But more importantly, when somebody dials 911 for a medical emergency, they expect that response as a public safety agency. If someone's breaking into their house, they expect the police to respond. If there's a fire at their location, they expect suppression equipment to respond. If there's a medical emergency, they expect EMS to respond. Okay, it is part of that community. And this has been improving over years, but I would submit to you that we still have some fairly significant challenges in our engagement with the emergency management community. EMS is a discipline that needs to be integrally involved in your emergency management programs and activities. So a little bit different than the focus on the medical director, but we need to get over the triad of EMS as the public safety net involving healthcare, public health, and public safety, and expand that to include emergency management. So what historically has been an area of tension in a lot of cases between a medical director and the administrative leadership of whatever the EMS agency is. I can't tell you the number of times that I had a couple of fire chiefs in Kent County call me up on the phone and say, "We need to talk." That is getting immensely better. But the physicians who are out there now and will be coming after us know EMS, they're interested in it, and they want to be a part of it. And they will help your agency, as demonstrated by the active EMS physicians that are involved in all the programs that we've been talking about so far.